Who is eligible for CAR T-cell therapy?
CAR T cells have been approved in multiple settings for patients with relapsed myeloma. Initially, those products, the two products that are currently available, cilta-cel and ide-cel, were available for patients with heavily relapsed myeloma. Based on some other trials comparing cilta-cel or ide-cel to some standard regimens that we would typically use after one or two or three prior types of myeloma treatment, those products were seen to be better than some of the standard treatments we had available, and now have become FDA approved in earlier lines of therapy. So after one line of therapy, cilta-cel has been available, and after two or more lines of therapy, ide-cel has become available for patients generally as a standard of care approach. So there are efforts to look at CAR T cells in earlier settings, potentially considering some use of CAR T cells in patients who had completed their initial therapy for myeloma and an autologous transplant. If they'd had an insufficient response to that whole treatment program. I know of at least one trial where they are enrolling some patients to consider CAR Ts after that. But I do see in the future that there will likely be more trials that are including CAR T cells as part of frontline therapy. But I think we're probably some years away from knowing how soon patients might be considering getting access to CAR T earlier than their current FDA-approved indications.
Besides the label indication, FDA eligibility criteria, what other things should be considered before going forward with CAR T therapy?
CAR T is a type of treatment that can be complex. It can require lead time for manufacturing, requires close contact with the clinic. It requires patients to have good fitness. They should be able to handle some of the side effects that may come up from delivery of CAR T cells, including cytokine release syndrome and the possible, although less common, risk of some neurologic issues with CAR T. In general, I think many patients are good candidates for CAR T. We want to make sure they're fit, their heart, lung, and kidney function are good, that they have preferably as good an option to get them to the CAR T under good disease control, and that they have the right support systems in place after CAR T to get them through the early post-CAR T period when they might be at more risk of having certain side effects. So having a caregiver support process in place, being able to get to and from the center is important, at least in our center, and I know at others. For patients who come from a great distance, they might need to temporarily relocate to be within a certain radius of the center, so that if some issue comes up, they have the ability to get care from the team at the center that has experience with managing the CAR T related side effects. All of these, really important and complicated factors play a role, but there are many patients who are good candidates, and I think that as we get more experience with CAR T and expand our ability to deliver it to more patients, I think it's going to be good for a wider group of people.
So CAR T cell therapy has been a fantastic addition to our armamentarium against myeloma, but right now I don't think everyone can get CAR T cells because of the toxicity piece. And usually it's patients that have to have an ECOG performance status of 0 to 1. So these are patients that are, otherwise doing really well and healthy. I will say that when it's standard of care, we have some patients that maybe aren't in that ECOG 0 to 1, maybe 2. And again, patients whose kidney functions and liver function and heart function are relatively okay. Because again, it's the toxicity piece. And hopefully as we learn more and more, we'll be able to get more patients on. For clinical trials, there's a hard stop in terms of have to have ECOG of 0 to 1. Your platelets have to be greater than 50 to 100. Your neutrophil count has to be greater than 1. Your platelets have to be greater than 50. Or your hemoglobin has to be greater than 8. So there's a lot more in terms of eligibility criteria with trials they're a lot more strict. So both ide-cel and cilta-cel have multiple trials that they're looking at different time points. So we're excited about one that's going to come out in Europe, that they're going to look against transplant versus CAR T for cilta-cel. That'll be really exciting. And then in the US, we have trials looking at CAR T maybe right after transplant. So a lot of data, hopefully in the next couple of years, that we'll learn a lot more from.
Besides FDA eligibility criteria, what other factors should be considered when discussing CAR T treatment?
But in terms of the other eligibility criteria of how the patient is, whether you think that patient would be eligible for CAR T or not, is based on the patient factors, the disease factors, and the treatment-related factors. What I meant to say is that how old is the patient, how is the performance status of the patient, what are the other comorbidities the patient has, what kind of disease burden the patient has, is the disease relapsing very fast or the disease relapsing slowly, and what are the other treatment-related issues the patient has, what are the prior toxicities this patient has, if the patient has baseline kidney dysfunction, the patient has baseline neurological dysfunction. So these are that things needs to be factored into account in addition to the eligibility, what is the label has been mentioned, and that is how we decide the eligibility of the patient for the CAR T.
Are there any age restrictions that may exclude an individual from CAR T therapy?
These are by far lower doses of chemotherapy than what we use in transplant conditioning, which also allows us to address the average age group that these diseases are common in. So we routinely treat with CAR T cells people older than 70, and we've treated a number of patients older than age 80. And the registry data in the United States, at least, shows that patients up to age 91 have been treated with CAR T cells. So we have no concern in doing this in older individuals, and we do not use age as a barrier or as a parameter for eligibility or whether it's appropriate to use CAR T cells.
While a patient may be eligible and a good candidate for second-line CAR T, is it always the right choice for them at that time?
I think this is a really important, cutting edge question of kind of where we are today in the myeloma field, and it's a challenging question. Certainly, we've seen from, at least in the second line setting, the trial that led to the approval of cilta-cel, the CAR-2 trial showed some great benefits for some of our patients who get CAR T over the standard available therapies, including, potential. We know that it extends the amount of time until the patient needs a different type of myeloma treatment greatly. And recently, I think the trial had also shown some survival benefits for those patients who got CAR T. However, CAR T has some issues with it. There are some complex side effects and complications that can come from CAR T that one needs to consider in the risk-benefit analysis that each patient and provider must go through to decide whether or not it's the right fit for a patient at that point in time. Some common issues that can come up with CAR T, the side effects that happen during the process, like cytokine release syndrome or immune cell-associated neurotoxicity syndrome or neurotoxicity can happen. Those are really short-term and likely temporary issues. However, we've also seen some more uncommon complications of CAR T that are worrisome, including there's been some rare cases of more permanent neurologic dysfunction, nerve injury, some rare cases of Parkinsonism. Additionally, second cancers, I think, is another major concern that is a more commonly seen issue. I wouldn't say it's common, but I'd say that it's a bigger problem than some of the neurologic concerns, although the neurologic concerns are certainly scary. Myelodysplastic syndrome has been a problem that's been seen in both using both of our available CAR T products, likely related to patients' prior treatment exposure history to certain types of chemotherapy, as well as potentially some of the chemotherapy that's used for the lymphodepletion to make room in the body for the CAR T cells. Really, the possibility of second cancers, I think, is a risk that is a known problem with CAR T. And I think that is something that we need to take into account when deciding whether or not someone should go to CAR T next. There are other quite rare entities like T-cell cancers that have been seen, but those are really, I think, much rarer entities. And I think I would say there's probably not a reason not to do it. But to kind of summarize, I think there's a great promise, and there's a lot of positive results that we've seen from use of CAR T, and having more treatment options available to get to CAR T under better disease control is more easily done in the second line setting than after that. However, the risks of second cancers, the complexity of CAR T, the need for hospital admission, taking time out of your life to go through the process, I don't always think they should. Certainly, my patients who have high risk disease, those patients who may have already have some worrisome signs of either aggressive type of myeloma, potentially those patients who might have a history of plasmacytomas, for example. Those patients worry me, and those are the people in whom I'm more likely to lean towards doing it earlier rather than later. But for those patients who've had, let's say an excellent, response to initial therapy, what appears to be not a rapidly growing, aggressive, high risk type of myeloma, there are a number of great options for use in second and line therapy that are not CAR T, and I think those are still viable choices. I always just like to try to think a few moves ahead, and to think about where I might be with a particular patient that we're making this decision with. Where are we going to be in the third line setting? What are we going to have available to us? And that's always an important calculation we need to make to determine, whether it's time to do CAR T now, or whether we should do something else that isn't CAR T and consider returning to CAR T later. And always hard to try to predict the future, but you always want to think about how can I maximize the amount of treatment options that my patient has, to try to help them get the best outcome possible. You want to maximize their options. So in scenarios where I think I might have CAR T as an option now, but for some patient-related reason or some other reason I might not have access to it later, that might also be a reason why I might think about doing it now. But this is a complicated discussion. I think that we really need to do as best a job as we can to educate the patients about the risks and the benefits of CAR T, because there are great risks and potential great benefits, both. But I think it is a really valuable treatment approach. Deciding when to do it and when to do it later or not to do it is a complex decision that it requires important conversations with our patients that need to help us get to that conclusion.